This will be a discussion of patients who have obstructive disorders of the lower respiratory system, specifically COPD, chronic obstructive pulmonary disease. Obstructive lung disease is a decrease in airflow caused by a narrowing or blockage of the airways. It is characterized by problems moving air into and out of the lungs. So when you have a narrowing of the opening of your tracheobronchial tree, this increases the resistance to airflow, making it difficult for the oxygen to get in and the carbon dioxide to get out. And it contributes to air trapping as well because exhalation is very difficult. Diseases that are considered obstructive pulmonary disorders are bronchiectasis, which we talked about with infectious disease, COPD, which we will talk about here. Diseases in this category include chronic bronchitis and emphysema, asthma, we talked about in another PowerPoint, cystic fibrosis, you reviewed this in pediatrics, and atelectasis, which actually can also be considered a restrictive lung disease. Currently, chronic obstructive pulmonary disease is the third leading cause of death in the US. It's more common in men, but increasing in women because more women smoke now. The diagram here, sort of a Venn diagram, is looks at the interaction between the three diseases that make up COPD. You normally think of emphysema and chronic bronchitis, but there can also be a component of asthma present. So really you need to think about all three of these diseases when you're talking about chronic obstructive pulmonary disease. Reviewing the pathophysiology of COPD, what you find is that patients have difficulty exhaling because their airways are blocked by inflammation and mucus and because of the loss of elastic fibers. So they use more effort required for their weakened alveoli to push the air out through obstructive airways. Airflow limitation is progressive and minimally reversible. So contrast that to asthma, where airflow limitation is almost always reversible. COPD develops slowly and actually is maybe present for many years before the symptoms become evident, and it may be advanced by the time the patient seeks treatment. COPD is characterized by periods of relative stability and exacerbations, which of course is acute worsening of the symptoms. These exacerbations can be triggered by infections or other stressors such as exposure to a chemical irritant, to smoke, to an allergen, as in with asthma, if there's an asthmatic component to it, can also be triggered by some stress, and other chronic illnesses can contribute as well. Let's look at chronic bronchitis. As I mentioned when I talked about infectious disease of the respiratory system, chronic bronchitis and acute bronchitis are similar. If you have acute bronchitis exacerbations 3 months of the year for 2 consecutive years, you are considered to have chronic bronchitis. What it looks like in an airway level is your tracheobronchial tree is inflamed from the inhaled irritants. Most often cigarette smoke is the inhaled irritant. That's the offending thing. And you can see that in this picture where you have really inflamed mucosa as opposed to the healthy airway next to it. The other thing that happens is you get reduced ciliary function, again, from the smoking, and so then you can't remove other irritants that are present, say perhaps bacteria. You get hypertrophy of your mucous glands, and they produce really excessive, thick, tenacious, sticky mucus, and that obstructs the airways and also traps even more air. And you wind up with what amounts to a chronic low-grade infection in your airways. Here's another way of looking at a normal lung versus chronic bronchitis. If you look at the normal lung, you have nice little open alveoli. If you look at the chronic bronchitis lung, you have a lot of secretions, really thick, tenacious secretions that plug the airway. And when you obstruct the small airways, the alveoli are deflated beyond obstruction, beyond the area of obstruction. And basically what that leads to is decreased areas for gas exchange in your lungs. The other disease besides chronic bronchitis that comprises COPD is emphysema. Emphysema affects the bronchioles and the alveoli. What happens is you get the destruction of alveolar walls and the loss of elastic recoil. So you get these fibrotic alveolar walls, and you look up there, you see healthy alveolus with wide open space and healthy membranes as characterized by fibrotic alveoli, very little air in those, and the membranes between them have broken down. When the membranes break down, you also get damage to the adjacent pulmonary capillaries. You get air trapping in these big, huge, useless alveoli, and so passive exhalation is impaired. You know how usually inhalation is active and exhalation is passive? Well, for these people, exhalation can be an active, and so an active process, and so that just increases the work of breathing. The other thing that happens when you've got destroyed alveolar walls and destroyed pulmonary capillaries is, of course, reduced surface area for gas exchange. So here's a normal lung versus emphysema. Again, look at those wonderful little open alveolar sacs in the normal lung as compared to the over-distended alveoli. The septal membranes are destroyed. The capillaries are destroyed. Nothing in this little alveolus works toward gas exchange. And if you look in the lung as a whole, what they're showing is all of these little alveoli and alveolar sacs have just been destroyed, and there is very little area for gas exchange in this lung. You'll also notice, if you look at the pictures side by side, how overinflated the lung is because there's so much air trapping and the person can't get the air out. If you can't get the air out, you can't get new air in. So you retain carbon dioxide and you don't get the amount of oxygen that you need back in. Risk factors for COPD include smoking, also secondhand smoke, and I'm going to go out on a limb here and say that smoking also includes vaping. So it's not just necessarily cigarettes, but also the e-cigarettes that you're seeing now. Pollution and chemicals can also be risk factors and can contribute to the development of COPD. There is a genetic form of emphysema where you have an alpha antitrypsin deficiency and you get emphysema very early in life, can be in your 20s and 30s. It is something that can be treated, but quite often you don't know you have it until it's pretty far advanced, and people aren't looking for emphysema in 20 to 30-year-olds. I do know people who have alpha antitrypsin deficiencies who have had lung transplants that have been very successful. Complications of COPD. A complication of emphysema is you can get a bulla rupture. A bulla is, they are large air sacs within the lung tissue. So if you recall that earlier slide, how the basement membranes in the alveoli break down and they just become one big, huge fibrous mass. And so it's almost like a blister, if you can think of that. And it ruptures, and this can cause a spontaneous pneumothorax. Pneumonia is a complication, and we talk about that in a separate lecture. Peptic ulcer and esophageal reflux, because you have so much air in your lungs, it presses down on the diaphragm, which puts more pressure on the stomach, causing reflux. Right-sided heart failure or cor pulmonale is something that happens because your right-sided heart pressures increase. You've got increased pulmonary artery pressures from the increased pressure in the lungs, and this is just like plumbing. Once you've got increased pressure one way or one place, it all backs up, and so it backs up into the pulmonary vein, into the right side of your right atrium, and then eventually right ventricle, and you get right-sided heart failure. Acute respiratory failure can happen from an exacerbation that is really bad, and death often results from an infection or pneumonia, basically, or respiratory failure. This picture gives you a visual representation of the signs and symptoms of COPD. This includes emphysema and chronic bronchitis. So exercise intolerance, very easily fatigued, frequent respiratory tract infections. Anytime these people get a cold, it almost always goes into bronchitis or pneumonia. When people are pretty far advanced, you will see use of accessory muscles to breathe. They are orthopnic. Orthopnea, as you recall, means you have to sit up to breathe, so they sleep on several pillows. You will hear wheezing from the airflow obstructions. You will often see pursed lip breathing. Sometimes you don't even have to teach people to do this. Sometimes they just do it on their own. You'll see the pursed lip breathing or chronic humming, which is another way to increase the air pressure, back pressure in your airways. Chronic cough. These people cough all the time with lots and lots of sputum production, particularly in the morning, because the secretions pool when they sleep and are at rest, and they get up in the morning and they hack and hack and hack and hack until they get it all up. Dyspnea. So dyspnea increases with exercise. So dyspnea on exertion is one thing, but then in the end stage of this disease, they're dyspneic at rest. They have prolonged expiratory time on their pulmonary function tests. We talked about spirometry with asthma, and we talk about PFTs in respiratory diagnostic test lecture. They will often have a barrel chest if they have emphysema. They have trapped so much air and retained so much air inside there that their chest becomes big. And you'll remember back from physical assessment that increased AP diameter when we talked about looking at inspection of the respiratory system. Sometimes you'll get clubbing of the fingers, and that's in pretty advanced disease. Cor pulmonale, right-sided heart failure, is advanced disease, and weight loss. People have to work very hard to breathe, and two things happen here. You use all of your calories to breathe, and then you are so short of breath that it's hard to eat. And so for those reasons, weight loss is very prevalent in this population. So diagnosis is often made with a chest x-ray or a CT. You'll notice on this chest x-ray where it says wall of bleb, those are those bullae or blebs that happen in emphysema when you have the destruction of the alveoli. You also notice that the diaphragm is very low. It's not a dome like you would normally see in a normal chest x-ray, and then there are hyper filled lungs here on this chest x-ray. You can also do arterial blood gases, and as you might suspect, your PO2 will be low. SATs are probably pretty low, and these people retain a lot of carbon dioxide, so they have chronic respiratory acidosis. A CBC only because sometimes you will get, for people who are really hypoxemic, you will get erythrocytosis, a lot of high red blood cell count, basically polycythemia. More red blood cells are made because you have chronic low oxygen, and the hope of your body is that more red blood cells will make more hemoglobin, and more hemoglobin will carry more oxygen. Doesn't always work out though, because if you can't get the oxygen in, making more red blood cells won't necessarily carry more. Pulmonary function tests, we talked about that in the respiratory diagnostics lecture. You will often see you will see decreased flows, and you'll often see decreased oxygen carrying capacity. Sputum cultures are taken if there is infection, and of course, in a young person, they will do an alpha antitrypsin level if they suspect genetic etiology for emphysema. Therapy, smoking cessation at the top of the list for sure. Much harder than it looks, though. I tell you, this has got to be one of the most difficult addictions there is to cure. And really, cure is a bad word for it. It's just to control. Bronchodilators are used, both beta agonists and anticholinergics. You'll use short-acting beta agonists, albuterol, for acute exacerbations, and then long-term treatment with long-acting beta agonists like salmeterol. There are anticholinergics that are used, ipratropium, and you'll see drugs like Duoneb that are administered through a nebulizer that have both. Corticosteroids are important. Inhaled corticosteroids, you'll notice this inhaler in the picture, the purple inhaler, is Advair, which is a combination of inhaled corticosteroid and a long-acting beta agonist. Expectorants and mucolytics are important to help thin out the mucus so that they can get it up. A lot of people wind up with supplemental oxygen either at night or sometimes during the day at home. Sometimes you'll get BiPAP support. BiPAP, as you recall, is bi-level pulmonary artery pressure. So you have both inspiration pressures and expiratory pressure. So you have increased pressure both with inhaling and exhaling to help keep what airways you have left open and increase the area available for gas exchange. Sometimes they will do surgery. If you have somebody with emphysema, they'll do a lung volume reducing surgery, LVRS, which means you've just got all this big, huge expanded lung tissue that is not good for much of anything, and so they'll reduce that and help to preserve the part of the lung that is not damaged and is available for gas exchange. You can also do lung transplants. As I mentioned, people with alpha antitrypsin deficiency will often need a lung transplant if they're to survive much past their 30s or 40s. Supportive care for these people is really important. Nutrition is something that is often overlooked, and as I mentioned in earlier slides, weight loss is a big problem in this population, and so high protein, high fat diets and low carbs. Why low carbs, you ask? Well, when carbohydrates are metabolized, you get a lot of carbon dioxide produced, and these people are CO2 retainers, and so high protein and high fat diets are much better. Plus, with a high fat diet, you get they're much more calorie dense foods, and so you get more bang for your buck with fat than you do with carbs. Hydration, really important to keep those secretions loose. Look at depression. This is a population of people who are often homebound. They can't do much because they're short of breath often, and they can really be depressed. The other thing is if people can't stop smoking, that can be really depressing too. We've developed this societal attitude that smoking is bad, which is a good thing. I'm not saying that's a bad thing, but then you kind of tend to demonize people who do smoke, and if they're really having trouble quitting, that can be very depressing. Chest physical therapy is important, especially for people with chronic bronchitis who have a lot of secretions. Pulmonary rehab, Super important to keep these people moving. And so pulmonary rehab programs that teach them how to do low-level progressive exercise is important, and vaccines. Influenza and pneumonia vaccines are crucial in this population to prevent pneumonia. Priority nursing diagnosis for COPD are very much the same as the priority nursing diagnosis in all chronic lung disease, impaired gas exchange, ineffective airway clearance, activity intolerance, and risk for infection. And that risk for infection is where a lot of your teaching is going to come in terms of immunizations, avoiding crowds, frequent hand washing, teaching the family to stay away when they're ill, that sort of thing. Very, very important to keep these people just sort of perking along and not having as frequent of acute exacerbations. Let's end with a case study, and I'm sure many of you will recognize people who have the same story as this gentleman. An older adult male is admitted to the hospital with a COPD exacerbation. He has a history of emphysema, and he now has an acute infection complicating his disease. His lung sounds are diminished. He has dyspnea at rest on 2 liters of oxygen per nasal cannula. He puts on his call light, and as the nurse enters the room, she finds him sitting at the bedside commode with a look of panic in his eye. He has a respiratory rate of 36. He's using his accessory muscles, and his skin color is ashen. So what are you going to do here? What should the nurse do first? What assessments are needed? And who do you need to call for help? Because this is somebody you're not going to deal with on your own. Well, several things need to happen at the same time. First of all, you need to speak in a calm voice and help him to calm himself. Doing pursed lip breathing is a good way to do this. Standing right next to them, breathing in and out slowly and deeply will help to coach him into doing that and help to relax him. Suggest the tripod position if he's not using it already. Leaning his elbows onto his knees or his thighs to open up uh, or move the diaphragm down and open up the chest. Also, you can get a bedside table for him to lean on and put him in that orthopnic position. Make sure he knows you're going to get help and then you're not going to leave him. At the same time you're doing all this, you got to check his oxygen saturations. Make sure he's got his oxygen on, first of all, because, people wear their nasal prongs in their hair or on their forehead, or they get up to the bathroom so they take their oxygen off, which is not such a smart thing to do. Also, if he's got it on, make sure it's not disconnected or make sure there's no kinks in the tubing because those things can happen too, and make sure it's turned on. People bring patients back from PT, put them in bed, hook up their oxygen, and don't turn it on. Check his saturations, if there's an oximeter in the room. If not, turn on that call light and get one ASAP. Again, use the call light, call the charge nurse for help, get a neb treatment from the nurse or RT, whatever the protocol is. I'm sure this person has a neb treatment ordered. So get one now. Have somebody bring an oximeter in if you don't already have one. Have somebody bring a vital signs machine in if you don't already have one. If the person has an IV, which they probably do because they're probably getting IV antibiotics and IV steroids, morphine helps sometimes. It can help open things up and relax them, slow the breathing down, get some oxygen in. So if that's ordered, get the nurse to bring that to you. Once it's calmer, and he won't be calmer until you get him to deep breathe, you get some oxygen in him, get a neb treatment in him, find out what happened. Did the exertion of moving from the bed to the bedside commode cause the dyspnea? recheck vital signs and lung sounds to see if there are any changes, and then talk to the charge nurse to see what needs to be done. Do you need to notify the provider? Did he get better with the neb treatment? Was it just that his oxygen was off and now that it's back on, he's good? A lot of different scenarios here can happen, but you need to get a real definitive picture from the patient as to what happened, and that cannot be done until the respiratory distress has subsided and he's calm enough again to talk. What can the nurse teach the patient to prevent dyspneic episodes like this in the future, and what documentation is required? Well, one thing you can do is to teach this person to probably stay in bed and ask for help to get up until this acute exacerbation has resolved. It's hard for people who are used to being active and at home and are maybe a little bit proud to ask for help. And so, reassure them that it's okay, that that's what you're there for, that can prevent this sort of really terrifying thing from happening. The other thing you can do is review the controlled breathing exercises to use, that pursed lip breathing, to use those when he's moving, and encourage him to do that when he starts to feel anxious or short of breath. Also encourage them to space their activities out and rest between activities. So, if he just got back from PT, needs to sit down and rest for a little while before getting up and trying to do anything else. Documentation. Let's say this happened at 3 o'clock in the afternoon. So at 3 o'clock, patient found on bedside commode, respiratory rate of 36 and labored, using accessory muscles, color ashen, and appeared apprehensive. You could say oxygen on at 2 liters per nasal cannula, give the vital signs, blood pressure 146/64, heart rate 102, SpO2 84. You could report what you hear lung sounds wise, so breath sounds diminished. What did you do? Well, neb treatment, list the medication, maybe some ipratropium or duoneb, albuterol, whatever it is you used. Neb treatment administered per order, encouraged pursed lip breathing, and assisted to lean on bedside table. So you did all this, and then you need to evaluate your care. So let's say at 3:30, 15:30, you chart resting in bed in Fowler's position, appears calmer, respiratory rate 24, less labored, no accessory muscle use noted, and SpO2 90% on 2 liters of oxygen per nasal cannula. That's just an example of something that I just made up that you might want to use when you're charting on somebody like this. Always remember to do a follow-up note to evaluate the care that you gave.